Routine phacoemulsifications and going towards more complex cases, many times we have a mental block that can I really use this device? Can I go, how do I manage it? How do I handle it? Or which one should I use? So my idea was to talk about that. So as previously discussed, we all know that small pupils are basically of two types. One is the floppy one which comes with IFIS, and the other is the rigid pupil, which may be because of diabetes or long-term use of local anesthetic combinations. Phenylephrine 0.1% with lignocaine and tropicamide, or you can use epinephrine with Oculan. That will help us to dilate the pupil intraop. Or another thing is we can use the mydriatic agent in the irrigation fluid to maintain the dilatation during the surgery. Now, if nothing of this helps, then during surgery, what we try first is we try the viscoelastic, that is viscomydriasis. We push in a good amount of viscoat or orocoat and try and dilate the pupil. When that doesn't work, we go to the other devices. And of course, right from the olden times, we have the mechanical stretching or sphincterotomy using the Y hooks. So, what are these hooks and rings and what are we talking about? So basically iris retractors, the previous speakers have mentioned, but I would like to give some finer points about these. So basically these are 50 polypropylene flexible hooks. So looking at the hook first we feel, oh, how do we use it? Oh, what will happen? Will I really go in and damage the iris? What would happen? So the important tip is that fill the anterior chamber well with a viscoelastic, and the paracentesis have to be really small. Now I'll discuss it when I show you the video. The advantage with the hooks is that it is affordable, 500 rupees, and you get a set of 5 hooks, and usually they are readily available in all the OT setups. The downside is that you need more incisions, it is slightly time consuming, and if there are other things like pterygium or bleb or keratotomy patients, then creating multiple openings may become an issue. And if the eye is very small, you have less space. So when you have these iris hooks, you have less space to manipulate your other instruments. Coming to the rings, there are various rings available. The most commonly used worldwide is the Maligan ring. We have our Indian innovation, that is by Dr. Bhattacharjee, that is a BHEX ring. And there are other pupil expanders used worldwide, which are not that very popular. Now, Maligan ring is slightly on the expensive side, but the advantage is that you do not need extra incisions. You can go through the main 2.2 or 2.4 incision, and it is basically a 40 or 50 polypropylene device which is square shaped, which has 4 scrolls, and it engages the pupil at 8 points, giving you a circular opening. Again, it comes in 2 forms. It can be either 6.25 mm opening or 7 mm opening. Now, what was the advantage with Malignant 2.0 was that it is being a thinner ring, it is less bulky, and the increased scroll depth will help to engage the pupillary margin more easily. BHEX is a hexagonal device, which is a plastic device actually. It gives 5.5 mm pupillary dilatation, and you need a 23 gauge micro forceps to actually place it in, and also you can use thin Sinskey's hooks to place the scrolls. Coming to the video, now this, if you see, it's a mid-dilating pupil, and with phenylephrine, it is giving a fairly good dilatation of around 6 millimeters. And now when you go in with dispersive viscoelastic like viscoat, you get a fairly good dilatation with a good view. Now when that is not happening, you go to hooks. So again in hooks, very small paracentesis, 1 millimeters, you can use the MVR or even the 15 mm blade, but ensure that it is parallel at the posterior limbus and parallel to the iris plane, so that you don't have a tenting of the iris hooks. To McPherson's forceps, be very gentle and careful. First, I prefer to just place all the hooks, just engage the pupillary margin. The silicone stoppers actually give a guide to the direction of how your iris hook is, and that will give us a fairly good idea. And once all the hooks are placed, that is the time when you go and stretch the hooks, only giving you an opening of around 5.5 millimeters. I prefer the hexagonal opening, but some people prefer 4 hooks giving a diamond shape opening, but I don't stretch it right up to the periphery. And my phaco probe is usually not having a hook below it. I do not find it like the iris has never come prolapsed to the main one in my case. Now coming to the rings, now this was a patient which required a toric IOL and it was a floppy iris. After I stained, you can see that the iris has started coming to the side port. So I knew that this is going to be a very floppy iris. Don't be fooled by the viscoelastic being injected and slight dilatation that you get, because it is going to come down again later. So here I wanted to use the malignant ring. Now the important thing here is that you try and engage two scrolls, but sometimes it may not be possible, and with your other hand keep a Kruglan's hook in place and you can easily in various directions go and engage the scrolls into the pupillary margin. Now after the phacoemulsification, when you put the IOL, you can place the, since it was a toric IOL, I wanted to place it along the axis. Remove the viscoelastic from the back, but let some viscoelastic remain in the AC, or if you feel you're washed out too much, go and inject a little bit of viscoelastic, because when you disengage the scrolls, you need the AC to be well formed so that it doesn't go and touch the endothelium. Very gentle mannerism, it easily comes off, and what I find is with malignant ring, actually the damage to the sphincter or pigment dispersion is pretty less in my hands. And then you can take it out with the Kruglan's hook itself, it comes out very easily. And yeah, so the pupil has come down, so we need to ensure that the axis is correct. So you can, under irrigation, just use your Kruglan's hook and visualize the axis well, and then end the case. So Kruglan's hook is a very good device to use when you just need it for some time to visualize what is happening underneath that small pupil. And another device, that is your B-hex. Actually, can I move it slightly? Can you give me the cursor? Oh, no, the next video. Yeah. For the B-hex, actually, it is very flexible, but it is uniplanar, and I feel that there is a slightly more learning curve to the B-hex. It is very floppy, and I don't prefer it for floppy iris. I mean, if you have a rigid pupil, yes, B-hex works better, but for floppy iris or IFIS cases, I feel the malignant ring does better. And just going to the next thing, the take-home message I would like to say is, good visualization again is essential for safe surgery. Use what is available and what you are comfortable with. Avoid trauma to the sphincter and the iris root, because you may be enthusiastic and you may pull, so that will cause damage and iridodylisis. And post-operatively, you may need to manage the inflammation and cystoid macular edema, which is seen slightly more in these cases, which may require devices to be used. Thank you. Thanks a lot.